name is Cogle. I'm an associate professor in medicine at the University of Florida at Shands Hospital. I'm the first speaker today, but before I begin, I do want to say welcome to everybody. Also like to welcome, of course, Dr. Rami Kamraji from Moffitt, who will be presenting later, Dr. Steve Neimer, who's the Cancer Center Director here in Miami and an MDS expert. And we also have Dr. Ferran, who I've not seen yet, who's coming from Mayo Clinic in Jacksonville. And then, of course, we have Sarah Tinsley from Moffitt, who will be presenting as well this afternoon. But the most important people in the room are all of you, who are here to learn about what MDS is, learn some new treatments, and we want this to be an opportunity in our breaks and then also the question and answer forum for you to even ask questions about your particular case or your family member's case. This is the reason for doing this. And then also thanks to the MDS Foundation, we have Debbie who's sitting out and checking everyone in. They are a foundation that supported MDS patients since the 1990s. Dr. Neimer is on the board for the MDS Foundation, and they can help you with not just information, but also if you are looking for a clinical trial or need referral to another MDS expert. And so let's begin. The first question, or the first topic today is what is MDS? So I've been charged to talk to you about what the biology of this disease is. I think when you break down MDS, I think there are 4 important concepts, and I'm going to present those 4 concepts to you. So before we go into concepts, let's break apart the name. What is myelodysplastic syndrome? So the name, if you break it down in Greek, it's myelo meaning bone marrow cells, dysplastic meaning funny looking, and syndrome, when we use that means group of symptoms. So this is a disease where a group of symptoms, usually fatigue, infections, bleeding, that's the group, presents. And if you look inside the peripheral blood or the bone marrow, you have funny looking cells. All right, we give it the fancy Greek name so we can sound more academic. All right. Now, the first concept is what I call the Picasso premise. All right. For that, think about when we look at art, like for example, Picasso's art. You can see here, this is how Picasso envisions a guitar. Okay, this is what my guitar looks like on my table. Okay, so when you look at Picasso, though, you need to know what a regular guitar looks like. Right? So that, and then once you know what a regular guitar looks like, you can appreciate what Picasso, and in this case the Cubists, were doing when they were pulling around the fretboard and the body of the guitar and the table. And the same parallel could be drawn for MDS. So before Dr. Neimer, Dr. Kamraji, Dr. Ferran and I, before we can diagnose MDS, we have to have years of experience knowing what normal bone marrow looks like. And so you can see here on the left what normal bone marrow looks like, and here's what MDS looks like. And so in particular, in an MDS cell, you have, in this case, it's supposed to be a neutrophil, and this purple is the nucleus. This is where all the DNA is, all the instruction, the computer programming for the cell. And here in the periphery, that should be chock full of granules, like purple granules. But instead, you can see here it's white. It's devoid of it. We also look at the red cells, and you can see here that this red cell should have a very dark, small nucleus, but it's a big open purple one, and it's also got a pink cytoplasm, or a pink where it's filled with hemoglobin. This is not something that should happen. As opposed to over here, you can see here's a normal red cell developing. Here's that dark, small nucleus, and then that cytoplasm filled with hemoglobin. So this, I may be telling you too much hyper-technical work, but this is the difficulty. And this is why some people with MDS can take years for the diagnosis, because some people are looking at Picasso paintings and not appreciating the normal bone marrow as its counterpart. And so that's why it does take some specialized centers that specialize in MDS to be able to tell this distinction. So, does this impact patient diagnosis? Of course. But it also impacts how we track this disease. So, for example, the cancer registry, which is located down here in Miami, what they do is they receive stacks of paper reports from pathologists that read MDS, and they are depending on pathologists to be able to say, yes, there are enough funny-looking cells in this bone marrow for me to call this MDS. And so this is the process. The paper reports get sent down to Miami, and they come up with an incidence of MDS is in 3 out of every 100,000 people. Now, we know, you know now that I've told you that it's very difficult to diagnose MDS. And so what I've done with some colleagues at Moffitt, with Alan List and Dana Rollison, is we've looked at using computer files that are sent to Miami, to the cancer database. And when we look at the computer files, and when us MDS experts are asking, instead of looking for terms like carcinoma, but looking for MDS words, when we ask that question, looking at the computer files, we find that the incidence of MDS is actually much higher than what our current registry database is telling us. And then when you look at people that are over the age of 65, whereas according to our registry, it's only 20 out of 100,000, but using our technique of looking through computer files, it's closer to 75 people out of 100,000. So it's triple the amount, over triple the amount of MDS that's truly out there. So that's the first concept. The second concept that I want you to understand are what I call clone wars. This is some new information that's come out of MDS. So when we look at an MDS bone marrow, you can see the cells that are pointed with arrows. These are the funny-looking cells. Keep in mind that the way that the cornerstone of diagnosis is with a light microscope, which was invented in I think the 1600s. So we're using very, very old technology as the cornerstone for diagnosing MDS. What the new technology we're doing is we're focusing in now on the MDS cells, and we're specifically looking at the DNA on the inside of these cells, because we think this is going to be much more informative about how the MDS cell will behave and how to treat the MDS cell. Now, just like I told you in the previous concept, you have to understand abnormal, you have to understand normal. So let me show you normally. This is the inside of a nucleus of a cell, and you can see a bunch of chromosomes that the cell has in there. So using computers, what we can do is we can reorganize those chromosomes and match them up. Okay? And so you have 2 copies of chromosome 1, 2 copies of chromosome 2, and on. So you get 1 copy. Sorry, I'm a little trigger happy here. You get 1 of the copies from your mom and 1 of the copies from your dad. So when your blood doctor talks about the cytogenetic report, this is the report that she or he is talking about. They're looking at the whole chromosomes. And what they're doing is they are comparing, for example, on chromosome 5. I'm not sure why this is advancing still. Richard, can you help me out here? There we go. Okay, so what they're doing is they're comparing the 2 chromosomes to see if they match up. Now that technology is a light microscope. I want to get us past that. Let's dig deeper. So for every chromosome, you can see here a chromosome. For every chromosome, there's about 5,000 to 10,000 genes that are within that chromosome. So we're going to go down to the gene level here. And so to understand what genes are, so you have a chromosome. Chromosomes are actually made up of wound up DNA. And it's supercoiled. So it's almost like those old telephone wires that we used to have where it would wind and then wind and wind, and it would take a day to get it unwound again. The DNA is very much like that. And so it's very much wound up, and the DNA is wound around proteins called histones. So it's wound up, and it's wound up in a way that what we've discovered is it takes certain drugs to open up these, like vorinostat, for example, is a drug that can open up that DNA so it's not so wound up. And so where the focus is going now is looking at the gene level, not looking at just the chromosome level. And that's normal. Let's take a step into cancer. So since the 1970s, we've known that genes are important in cancer. And the concept, one of the first major understandings in cancer was this model right here, this colon cancer model. And what we discovered was that it takes a mutation in the genes in the very beginning. In the colon cancer case, it happens to be APC, although it's recently known that APC is also involved in MDS, coincidentally. Then there is some other additional changes to the DNA. Then you get a third mutation, a RAS mutation. Then you get a fourth mutation. Then you get a fifth mutation, and then a sixth mutation, finally P53, which is a very important gene in our cells. And once you stack up all of these mutations like this, you eventually get a cancer formation. This is a very important concept in blood and in cancer, and the hypothesis was called the multi-hit hypothesis, where it takes not just a single hit, not just a single mutation in a gene, but multiple mutations in a certain sequence for you to actually get a cancer or get a blood problem. So this is held true for decades now, and this idea of a sequential adding of mutations, that is true. But where this hypothesis is failing us is that it's not just one pathway to cancer, and when you cut out a cancer or you take out some bone marrow, it's not just one MDS cell, but it's actually a group of multiple clones of MDS cells. So let me show you that data real quick. So there's a very interesting publication this past year by some Washington University investigators, which took bone marrow from patients that had MDS, and these patients ended up developing leukemia, where they took bone marrow again. So this is a very unique opportunity to have a longitudinal capturing of MDS and the same people with their leukemia. And what they found, first of all, is that there are multiple clones. So in green is the amount of normal blood stem cells. So in this particular patient, about a quarter of their bone marrow was made up of normal stem cells. But they found, interestingly, that there was a clone of MDS cells, and which is represented in yellow, and that this initial clone then gave birth to a daughter clone. So what this is all what this suggests is that there's actually a stem and a cloning and a daughter cloning and a granddaughter cloning of MDS. So let's take this a step further when this patient developed leukemia, and now look at all the granddaughters and the great-great-granddaughters and the great-great-great-granddaughters that all came from this initial clone. So when we treat MDS, when we treat AML, we're not just treating one disease, we're actually treating 2, 3, 4 different types of MDS that are within that bone marrow. Now, what about when in the case, hopefully with everyone in this room, where you've received some treatment and you improve the MDS? What happens there? So again, we have our MDS patient. Actually, in this case, this particular patient, had leukemia. So it was a very advanced MDS and leukemia. And you can see here the daughter clones that are coming up and forming, gave the chemotherapy, and look what happens to the clones. Most of the clones go away. You can see in particular this purple clone grew and then got chemotherapy, and the purple clone was extinguished, gone away. But there was a clone out of this mix of clones here. There was one clone that survived that leukemia, or this chemotherapy, excuse me. And with time, that clone can reemerge and actually give birth to granddaughters again. So this is a case where we're now capable of following separate clones on the inside of MDS bone marrow, watch them in reaction to treatment, and then look out for them if they try to reemerge at a later time. Right? Now this technology you can't see this on a light microscope. The naked eye cannot see this. This requires a technology where we look at the DNA sequence. And right now it costs about $5,000 to have this done. And usually right now it's only research labs that do this. There's no commercial lab that can do this. And what it takes is a bone marrow biopsy and a cheek swab, and for us to be able to compare the genes and the DNA between your cheek swab being your normal cells and the bone marrow containing the disease. This technology is getting much cheaper. A couple of years ago, it cost $10,000 for us to do this. So as it's getting cheaper and cheaper by the year, what we're predicting is that we're going to be able to do this for every patient and have just a tremendous amount of information on which genes are mutated and how many clones are in there. This is one of the most exciting times in blood cancer research because we are on the verge of having truly personalized medicine for people with blood conditions. Okay, third concept, which I call absentee parenting. So a normal parenting, so this is my kids, and Dashiell is 2, and Silas, which is underneath me, is 1. And what I've learned from parent, and I also have 2 4-month-olds, so I'm changing an ungodly amount of diapers. It's crazy. What I've learned, though, in parenting, and most of you in this room have grown kids. I know, Nancy, you guys have grown kids. What I've learned is that there's no amount of safety gates and safety locks that you can put on that nothing can compare to you watching your kid and being in the room and being engaged with them. And so that is hopefully proper parenting. I don't know. They'll probably still end up in a counselor's office when they grow up, anyways. But that's the parallel to what happens in the bone marrow. So the bone marrow is not just a bucket that contains stem cells. The walls of that bucket are very instructive. They're parenting. And so here's a section of a bone marrow. You can see that the circles are cells, stem cells, progenitor cells. This pink is bone. And again, that's not just concrete. It's very important. There's cells that line this bone that tell these stem cells when to wake up, when to go to sleep, when to take out the trash. They're very instructive. So the blood stem cell has been studied for decades, and it really came out of our fear of another atomic bomb going off. So the 1950s and 60s was really the big kickstart to understanding this blood stem cell, since that was a major toxicity with atomic bombs. There are 3 things that we know about stem cells. 1, they self-renew. They stick around with us for our entire life. Number 2, they can create many different types of cells. They can create platelets, they can create white cells, they can create red cells. And thirdly, they can sleep. So when we do computational modeling of stem cells, we use a computer to figure out how often they sleep. We think that they sleep on average around 20 years, 10 to 20 years before they wake up, make the white cells, red cells, platelets, and they go back to sleep again for a single cell. So obviously we cannot rely on one cell waking up every 10 to 20 years, and so that's why we've got millions of these stem cells that are in constant states of waking up and going to sleep. So who tells them when to go to sleep, when to make cells, when to divide again? And it's what we're finding out, it's bone, it's the blood vessels, it's also the nerves, it's the fat, it's the fibroblasts. There's lots of different scaffolding on the inside of the bone marrow. So in my lab, what we've done is we've developed a mouse model where we can look on the inside of a bone of a mouse while the mouse is still alive. And over several days, what we can do is we can, for example, transplant in a green fluorescent stem cell, and we can track where these stem cells go to. So you can see there's 12 hours, day 2, day 3, day 4, another day 4. And we can track where they home to, so you can see they home right to the lining of the bone, and then they start to set up shop, where they start to make the red cells, the white cells, and the platelets. And so even though we've understood what blood stem cells are, we don't know what controls them. And that's why this is a very active area of research, is the scaffolding. It's the microenvironment of the stem cell. Now so this is normal. I told you that to understand abnormal, we need to understand normal first. So here's abnormal. So here's our model again of the microenvironment. And there was a very interesting report about a year and a half, 2 years ago by a researcher named David Scadden and his group up in Boston. And what they did is they created a mouse where this mouse could not create bone cells very well. And so you can see here, oh no, excuse me, before I go into that model, here's a sort of a diagram that explains where these normal stem cells can come in, they can self-renew, they can make lots of cells, and then they can go to sleep. So what this Dr. Scadden and his group did is they created a mouse where there weren't a lot of bone cells. And then when they put cells, hematopoietic blood stem cells into this model, what they found is that when you don't have parenting bone to guide the stem cells, they actually form dysplastic cells. And these dysplastic stem cells then went on to make dysplastic red cells, dysplastic white cells, dysplastic platelets. And so we are now appreciating that the possible origin of MDS may not be the blood stem cell. It may actually be just bad parenting, bad bone. There may be other elements in that environment that also are contributing to this absentee parenting. So this is, and also in a very exciting way, this may point to new treatments to keep away the MDS after you've got a good response to either chemotherapy or Revlimid or transplant. And so this is new findings, and it's really opening up a lot of opportunity for us. Okay, and so the fourth and final concept is our sanctuaries. So where do these MDS cells go? Where do these malignant myeloblasts, where do these cancer cells go? So there's work in my lab that has found that we believe that blood vessels are very important in hiding these MDS cells and these leukemia cells. And so here's sort of a diagram of this hypothesis and where we're headed to. It's the idea that these myeloblasts can come out of the bone marrow. They go into blood vessels. And we have evidence that they can actually turn into blood vessel cells. So they can morph and they can mimic a blood vessel. We then give chemotherapy, which gets rid of most of these malignant cancer cells. But that over time, what we found is that these same blood vessel cells can actually give rise back again. They can give rise to the MDS and leukemia cells, which then can go back to the bone marrow and repopulate that bone marrow. And so we presented these findings about 6 months ago at the National Hematology meeting. The other interesting thing we're finding is that these MDS and AML cells, they're not strictly blood cells. They actually mimic the blood vessel cell, like I mentioned. And so they express receptors that you wouldn't typically find on blood cells, things like vascular receptors and inflammatory receptors that are usually only on blood cells or on blood vessels. Well, this gives us a great opportunity to attack the MDS and leukemia cells in a very different way. And so one of the ways that we're doing that is we're actually attacking the blood vessels that are supporting these cells. And so we've been working with a company that has found a natural molecule out of the bark of a South African willow tree. It turns out that it is very potent in getting rid of the blood vessels that support, that parent that leukemia cell. But it also has a direct effect on the MDS and leukemia cells themselves. And so we tested this in animals, showed that it worked, published that, and then we've now received FDA approval for this clinical trial, which we started about 1.5 years ago. And we've treated several patients. We're doing a dose escalation at the University of Florida of this drug. We're up to the 5 milligram dose, and we're constantly screening for new people. MDS patients that have excess blasts and that have failed previous therapies are eligible for this trial. And in short, we are seeing responses. We have about roughly a 40% response rate in this trial just by attacking the blood vessels that are supporting these leukemia and MDS cells. Okay, and so with that, I want to thank you. Thanks to the MDS Foundation for all the support of our clinic and our patients, to the University of Florida, and then to several funding agencies that keep our research going. Thank you for your time. Yes. Oh, the tree. What's the name of the tree? South African bush willow. Yeah, the bush willow. And it was actually found, you know, when Nixon created that war on cancer back in the 60s or 70s, I think it was. They gave a lot of money to the National Cancer Institute, and that National Cancer Institute supported researchers to fly around the world looking for anti-cancer agents. And one team that was in South Africa in the 70s heard from some Zulu tribespeople that this particular bush was used by the local people to treat tumors and their own cancers within the tribe. And so they dug up a bunch of plants and brought it to Arizona, where they were growing them. And it wasn't until the 80s or 90s that they figured out which molecule in the bark was the active agent. And it wasn't until in the last 5 years that we've been using it for the blood cancers.
Another question.
Yes.
You were talking about research being funded into your organization here in Miami. Is that the National Register for MDS, or is that someplace else?
So the question is, when I mentioned the Miami research in the first set of slides, that was in conjunction with a group called the Florida Cancer Database System, FCDS. That is a partially state-funded organization to track all cases of cancer in the state of Florida.